All right. So today we're going to finish this up. May not take that whole first hour, and then we're going to start our pain with our guest lecture. So we'll get into that next. So I'm going to finish this up, and then we will move right along. All right. Everybody on niacin? We're all here? Yes. Okay. So when we talk about, were we on the slide before this one? Why y'all giving me the face already today? Oh, it was test day. Okay, we get a pass. I forgot. Okay. So when we're looking at niacin, remember how I kept telling you with some of our drugs we can have the benefit of seeing that increase in our HDL, but we're not going to use our med to do that. This is our big one where we see a lot of increase in our HDL. So the way that this one is working is it is trying to stop that VLDL formation from happening. And so we want to get some of that, decrease the amount of secretion that we're having of that VLDL floating around. Remember, our VLDL was at the very beginning, and it was what was kind of transporting our horrible triglycerides around, and it can be turned into LDL, which was that good or bad? Bad. We didn't want any of that. So my big thing with my niacin is stopping that VLDL secretion. So therefore, I can down and indirectly stop the amount of triglycerides and all the LDL, the bad stuff, from being around. When we're looking at the clinical effects, again, I told you this is the one that we see that is good, very good with raising our HDL, but not why we are going to be prescribing this. I can prescribe this because it's pretty good with lowering my triglycerides, and I can also get some effects with lowering my LDL, but it's similar to a low-intensity statin. Did I use my low-intensity statins a lot? Not really, right? Those are for the things in our patients who are like, hey, I can't tolerate it. I'm experiencing those myopathies. So you see that your bigger thing that you're using your niacin for most of the time is going to be to lower the triglycerides, or if you have someone on a statin and you're just trying to get them like over that hump just a little bit more, you can add this on with that as well. When you're looking at your pregnancy category, the big thing here is just make sure that you are not doing this. Okay, so for you, it's a no. All right. Looking again at my clinical uses. When I'm talking about these, again, I can't take a statin, or I'm very close to my level, my goals that I want to be at, and I'm trying to like get them there with just a little bit of push, because remember, this is similar to my low intensity statin, which I don't get a big decrease in that LDL with my low intensity statins. But if I'm close to my goal, I'm close to my LDL level, I'm likely to get them there if I add this on. Adverse effects. So with this, the big thing that we see is going to be flushing, which is a lot of the times why we can't get our patients to the maximum goal that we want them to be at for those lowering effects that we see with their triglycerides. So the way that we try to reduce this flushing is we try different little mechanisms, or we mess with the formulation of the drug. So we have our extended release, right, which I can have it go through that ADME process a lot slower, and therefore I'm not getting all of my drug hitting my patient at once. It's going to be slowly released. I can also give them aspirin 30 minutes prior to them taking that niacin dose, and hopefully that will decrease the amount of flushing that they have. Getting creative again, taking it with some meals, sometimes that may help reduce the flushing. Now, when I say reduce, that doesn't mean that it may completely go away, right? I can still have some of that flushing occur. You can still see redness in people who are lighter complected, that have a lighter complexion. You will see that they can sometimes, they'll turn red. Some of your patients will also tell you that they feel kind of hot whenever they're taking this medication. And then, of course, decreasing the dose. But our goal is to try to get them to that target dose that we want them at. So if we're having to do that, despite doing all these other things with food, giving them that aspirin prior to, then we may think about switching them to another drug. Your liver toxicity, yes, I get the benefit of having that sustained release, decrease my flushing, but now I've increased the risk of having that hepatotoxicity, right? So it's kind of like one trade-off for the other flushing. And then with this precaution in your patients who have diabetes or any type of hyperglycemia, which is what we're typically worried about when we're talking about our diabetic patients. When you're looking at this, if you see that your patient has uncontrolled diabetes, okay, whether that means that they're having a lot of hypoglycemic effects or hyperglycemic effects, if it's uncontrolled, then you're going to want to be very, very cautious with using this medication. Or you have the patient who just is like, oh, I have diabetes, I'm not going to take the meds that you prescribe me, doc, thanks. Okay? They're uncontrolled. These patients, when we're talking about them, what you're looking at is that if they are monitored and if they are controlled, they may have to change their normal regimen that they're on. Okay? So you may have to adjust their insulin. So this is going to be you doing that med rec and saying, hey, all right, I see that you're taking insulin, or I see that you have this dose of metformin or what have you. We're going to keep your log and see if this medication, if this niacin is going to cause your glucose levels to now be changed, because then we'll change our medication doses that they were typically on prior to that. When you're looking at this, your niacin, your sustained release now, again, is coming out to be the one that has the benefit. You're less likely to see that hyperglycemia occur in those patients whenever you give them the longer acting. So we have some benefits to it. We also have those drawbacks to it because of that toxicity. Looking at your hyperuricemia, again, this one is the one that we were worried about with the patients who have gout, right? Because I have an increased level of that uric acid, I'm more likely to have that person who has gout have more flares. So we need to be very cautious in those patients as well, okay? Looking at one of the big disadvantages that we have, I do not need you to remember these doses. Just remember we have extended release, sustained release, and our immediate release, several different formulations for us to try to combat that flushing that our patient was experiencing. So when you're looking at this, what I want you to make sure of is that you're looking at what you're monitoring. So at baseline, I want to have my LFTs, and then every 6 to 12 months, weeks after, I'm going to continue to monitor. Once they are more stable, they have been on the medication for a long time, if you can get them to that target dose without all of those side effects, then you can start to monitor yearly, okay? So baseline, 6 to 12 weeks, we kind of like to look at that 6 weeks more often than not, and then yearly after that, once you say, all right, we're stable. Your contraindications, when you're looking at these kind of make sense in the sense that we were talking about our LFTs, we're talking about potentially causing hepatotoxicity with my medication. So looking at what my contraindications are, I have my patients with liver disease. This gout, we will see sometimes our patients who have gout, who we do use this, but it's like very rare because we are likely to see that hyperuricemia occur. So not very often that we're going to do that. Active ulcer, so I would, if I give you something like that, I would tell you that it is an active ulcer, and then that hypersensitivity to the niacin, if they ever tell you, hey, I used it before and I was, even at low doses, I was experiencing a lot of that flushing uncomfortableness, then we need to make sure that we're watching out for those patients. Bile acid sequestrants, or BAS. When we're looking at these medications, essentially our bile is made from cholesterol. Okay, so remember we talked about things and how we hear some of these words and we're immediately scared of them, but we need them for our body to function properly. So our bile is made from cholesterol, and then after they're produced, they're bound from circulation by these medications that we're talking about, so our bile acid sequestrant. And then this causes the liver to then uptake more cholesterol to make more bile, okay? So you're essentially getting that cholesterol out of circulation so that we can make more bile. When you look at this, the big thing that you need to tell your patient is that this medication is not absorbed. So they will sometimes see the shell of the medication in their stool. And they're like, oh, this medicine isn't working, because they see it coming out the other end. You need to let them know, hey, the medication did what it's supposed to do. That's normal for you to see that excreted in the feces. Remember, if anything comes out different color, we let our patients know, because those are the things that they can see, and that's what makes them not be adherent to their medications. Okay, our actions, we see again that this is similar to our low intensity statin. What did we just talk about that was also similar to our low intensity statin? Niacin, okay. You see that you also can potentially have an increase in your triglyceride level. Do we want to do that? No, okay? We don't want to increase our triglyceride level. So if you were having to use this because somebody couldn't tolerate a statin, you need to make sure that you're looking at their triglyceride level to make sure they're not also borderline for that, okay? If they have hypertriglycerides, right, elevated triglyceride levels, then we need to make sure that we are not going to put them on a VAS because that is going to further increase those triglyceride levels, okay? So looking at this, making sure that you understand that that increase could happen, and then for your patients who can't tolerate a statin, just like we said with our niacin, following that same line. You see that we can use these in our patients who have type 2 diabetes as an adjunct medication to keep them monitored very well, and then reducing the half-life of some of our medications, because remember how I just told you that it's not absorbed very well. So this can also bind to some of our other medications and not let those be in our system as long as they should. Okay, so it reduces their half-life. What happens if you reduce my half-life to my efficacy? Does it go up or does it go down? I don't hear anybody really. Okay, let's thumbs up if you think it goes up, thumbs down if you think it goes down. Right? Thumbs down. Okay? Because I'm getting rid of you now quicker. My half-life has reduced. I'm getting you out of my body a lot faster. Okay? So that is sometimes a good thing depending on what we're trying to do, but sometimes I may not want that. I need it to stay in there for the specified the half-life that I wanted it to be. Looking at your different drugs that you have available, remember I will give you the brand in the generic name. So you have your cholesterol, your cholestyramine, and your cholecelbum. When we're looking at these, I just want you to remember, God bless you. Remember the pregnancy stuff that's listed here on all of these. They're pretty safe in pregnancy. We don't really have any issues with them. And then looking at your less GI adverse effects, and doesn't interact as much when we're talking about our well call. So our well call is more friendly with other drugs if they were on something else. And our pregnant women are safe to take any of these. Okay. The dosing, I don't need you to remember all of that stuff with the doses. Okay. Looking at my adverse effects of these meds. So think about something that is not absorbed. I am having, and it's passing in my stool, so I think about it as expanding or making me feel more bloated, that GI upset and disturbance that they're having. So you see a lot of bloating and constipation that's happening, and that's why we have a lot of our patients who do not want to take this medication, because they're so bloated and uncomfortable. You see 40% of our patients sometimes will stop taking this medication due to the adverse effects. So just let them know that that is something that we can give them another medication for, but you know how I feel about giving a med to take another med, right? So if this is the only option that we have, we will give this med to take another med. So that's where you see you can give them stool bulking agents to kind of help them using the restroom, kind of give them something to help with the gas if they are having a lot of gas and a lot of bloating. So we do have, bless you, our meds that we talked about last semester in your GI section that you so love. Those are the types of medications that we would use, okay? Looking at your absorption of other drugs, again, we talked about that already, just making sure that you understand that in order to avoid that, we can still give this, but we're going to say, hey, you're going to separate when you're taking that medication with when you're taking your BAS. So I can give 1 to 2 hours before or 4 to 6 hours after they have taken another med. Depends on that person's schedule as to which one they want to choose. Try to tell them to stick to it so that they get used to taking that medication the same exact way. Okay. Looking at some of your medications that you have interactions with, those are all listed here. Just understand that they kind of just interfere with each other, so that's why you see that decreased absorption of those other drugs, which means they're not going to be as effective as we would hope for them to be. Contraindications that you see for your patients who have a triglyceride level that is over 400, we're going to want to avoid this medication because I'm going to just increase that potentially in my patients who already have high levels of triglycerides. Okay, so remember that cutoff number that's listed there. Okay, remember our ezetimibe in the chart. Remember, we were like, okay, I'm gonna start them on a statin, whether that's moderate or high intensity, and then if that's not working, my patient still isn't at their LDL level goal, then I can give them that ezetimibe, and then we talked about the PCSK9 inhibitors as well. This was the first one that we were gonna try. So looking at ezetimibe or Zetia, very good medication. What it's doing is it is trying to inhibit or decrease the amount of absorption that we have of cholesterol from our exogenous sources, so like my diet, as well as my endogenous sources, which my body is going to already make that cholesterol, like we talked about in the very beginning. So when you're looking at this, again, that's why you see, even if somebody isn't eating or they're eating poorly, or not eating poorly, it still helps us kind of get those levels together because we have it also working on the endogenous cholesterol that's being formed. So you're tackling it in two separate ways. And if somebody is on a statin as well, we should definitely see the results that we want to see. This is also the medication that I told you that sometimes if your person can't tolerate that statin and you try to alternate every other day, you try to put them on a low intensity statin, you've tried other medications that you've had, our second line medications that we had, you can also go to ezetimibe and just try to put them on the ezetimibe. It may require a prior auth or a medical necessity from you, but you would have that documentation and say, hey, this person can't tolerate the statins. If they come to you and you don't see that there's a history documented, you can try to see if you can get their medical records so that you can document it to submit it to TRICARE so that they can improve your medical necessity form. So clinical effects, low intensity statin again, you see a slight increase in those LDL levels, which that's just an added benefit, and then very small decrease in your triglycerides, okay? So main thing that you're using this for is to try to see if you can get some of that LDL level down, and it's trying to push you over that hump. You have a person who can't tolerate one of your statins, we can also go here and try to treat our patient. For the most part, you see that this is added on, and this was on the bottom of that chart that we were going to remember. When you're looking at this, the primary hyperlipidemia and I'm not going to ask you that way. I'm just going to ask you to know like what we're using this medication for. You're adding it to a statin, or if somebody absolutely cannot tolerate a statin and you've tried everything else, you can also just try to put them on this by itself. Okay, just the ezetimibe by itself. Okay, don't worry about trying to remember all of this. When you're looking at pregnancy, don't do it. Okay. We see that we had some adverse effects that we saw in our animals. Your interactions, again, with our bile acid sequestrants, 1 to 2 hours before, 4 to 6 hours after, it's still the same thing that we just saw carrying over. And then we have a great benefit. We like to decrease our pill burden for our patients so that we can increase compliance. And here we see that they have taken ezetimibe and added it to our statins. So now I can have my person just take 1 pill instead of them having to take 2. So this is just letting you know that I can give them a combination of those 2 medications together, and now they are taking 1 pill instead of me adding on 2 medications for them. Also, if I have a person who is like, oh, my myopathy, I'm starting to hurt, right? I'm having these pains because of the level of statin that you have me on. I can also decrease the amount of statin that I'm giving them because I'm kind of covering them a little bit with the ezetimibe, but in a different mechanism, okay? This is our wonderful PCSK9 inhibitor. So typically what PCSK9 does is it normally binds to your LDL receptors to promote LDLR receptor like degradation. When it is inhibited by this drug class, our PCSK9 inhibitors, your LDL degradation is now promoted, which is what we want, because there are more receptors now being on the surface of these cells to kind of grab that LDL out of circulation. So then we'll see a decrease in our LDL serum concentrations, which is what we want, okay? So they're going to bind to those receptors and they're going to degrade the LDL, so therefore we don't have it floating around, okay? That is your mechanism. And then you see you have increased clearance of your LDL, which is what we want. We want it out. Looking at our clinical use, this is something that is very, very good to decrease those LDL levels. Whenever we talk about these drugs, what do we see at the end of these? What does that say? MAV, what do we know about our MAV? Right? Those are our monoclonal antibodies and they cost a little bit of money. And we're gonna use these like last line. Use these in our situations where, hey, they're not able to tolerate that statin. Hey, they're not able to get to that LDL level even when I'm just trying to give them my good old ezetimibe. This is where you're gonna end up going for a lot of those patients. So you see here, adjunct to their diet, we're just trying to make them as healthy as we can. Also, we see a mortality benefit. I think this is the third one in this slide deck that we have that kind of helped us with that mortality benefit. So that's also very important because we want our patients to live longer. So this is your medications that you have available, your Praluent and your Repatha. Don't worry about the doses. What I want you to understand is that they have to get injections now. Okay, these are not oral medications anymore, they're injections. Looking at the cost, you see how that's pretty penny per dose, $672 a dose. Don't need you to remember that, just want you to remember you have these medications as options and they're sub-Q injections that your patient is going to get, okay? And they're helping us lower those LDL levels. When you're looking at these adverse effects, the big thing that I want you to remember is think about flu-like symptoms. Think about the way that your patient is going to present with the flu. They might cough a little bit. They might have some nasal congestion. If you remember flu-like symptoms, that can kind of get you to where your adverse effects are. Also remember, anytime you inject somebody with something, they're going to have that injection site reaction. I'm going to tell you that it hurt because you pierced my skin and I'm mad. Okay, here are some of our other meds that we do still see used, just not as often. And typically they will be add-ons to some of our other medications. So looking at your omega-3 fatty acids, you have two different types that can be in there. You have your EPA and your DHA. You can also get this from your diet and some of our fish. So just understand that a lot of this, when we made these medications, some of them we're going to also have to watch out for our patients who have fish allergies because of the way that they're made. Your mechanism of action, I just want you to remember that it's unknown. I'm not going to ask you all the other stuff. Just remember it's unknown. We don't fully know how this one works yet. Big thing that we're getting from this is lowering that triglyceride level. And then you see that I may raise up my LDL if my levels are very, very high. My triglyceride levels are very high. Because I'm likely to need a higher dose of this medication as well, and therefore I can also see my LDLs go up, which is not what I wanted to see, right? And then looking at that modest HDL increase, again, not what we're using it for. Another thing that I want you to make sure that you're understanding is that this is safe for us to use in our patients who have diabetes. Our uncontrolled patient, what medicine were we avoiding? Our uncontrolled diabetic that can cause flushing. Nice. Okay. So make sure with this one you're like, oh, doesn't matter if they have diabetes, I can use this one. Because remember, a lot of our patients are probably don't have some diabetes. They like the sugars. Okay. Looking at our different types of products that you have. So this is just varying based off of how they made the drug. And so this one has your EPA and your DHA in it. When you open these bottles, sometimes you can smell the fish. Like it smells very fishy. And the capsules are pretty big. So if you have a person who does not like to swallow capsules, they kind of look like this. No, I'm just kidding, they're not this big. They're pretty big. They're pretty big. If you have a person who cannot swallow pills, like this is not for them. This is not for the weak heart. I'm going to try to see if I can go find y'all a pill. They're pretty big capsules. And so, again, if you have a person, I tell y'all about gag reflexes, I tell you about like if somebody is not a good pill swallower, don't give them this, okay, because they're not going to be able to do it. You see that the higher the dose, you're also likely to see some increased bleeding risk, okay? So this is important for us to watch out for with patients that we have on anticoagulants. So if that dose is over 3 grams, and I want you to remember that little line right there, then I'm likely to see the increase in the platelet inhibition, as well as me having now that increased risk of bleeding. And then this fish allergy, okay? Make sure you let them know when they burp, it's gonna smell. It's gonna smell like fish. Thank you, Bert. okay? And that should help you remember that I need to watch out for my patients who have allergies to fish, okay? So any of your patients who have any allergies to fish or any sensitivities to fish, we want to watch out for this. And then you have your Vasepa, which only has your EPA in it. And so this one, again, with these also, when y'all are ordering them, look at it because sometimes they're on the formulary, sometimes they're not on the formulary. We like to change the formulary up a little bit. So just make sure that it is one of those that you're prescribing. Make sure that it is on the formulary at the time. If it's not, sometimes what it'll do is it'll hit you with that PA or you're going to have to do the medical necessity form. Okay, so it does change. So here, same exact thing, just understanding that we're trying to help us with those triglyceride levels, and then looking at your women who have triglycerides that increase while they're pregnant. You can potentially see us using these medications in the pregnant women as well. Over-the-counter options, we do have them in the pharmacy. If they are on the formulary, just prescribe them so that your patient doesn't have to go and spend their money for them. And then again, we already talked about those adverse effects. So just think about like just GI discomfort, burping, fishy smell, gray light. But we're reducing those triglyceride levels. So, okay, Metamucil. How many people have seen Metamucil? Metamucil, right? I can go get it over the counter, but I also have it in the pharmacy for our patients. It's not the brand name most of the time, but we do have it, okay? You see here that this is our bulk forming laxative that we're going to use, and this can help with minor like decreases in LDL levels. Again, not something that we typically see used because most of our patients are going to need more than a 5% reduction, okay? So this is not the primary reason why we will see a lot of this use. And then our adverse effects, again, some more gas, some more bloating. All right, this is just giving us all of our different options that we have. So you have a low intensity statin that you can give a patient, and this is when we would typically use our low intensity statins for our patients who are not able to tolerate those higher doses based off of our chart that we looked at, okay? So looking at this, most of the time, our second line drugs are equivalent to these low intensity statins. When you're looking at your non-statin therapy that we have, remember that I can have those as add-ons, I can have those as drugs to reduce the amount or the dose of my statin that I may need. And if my patient can't tolerate it at all, I can start trying to stack those on and see what response I get. Most of the time, you're going to end up using your PCSK9 inhibitors in those patients to get the lowering effect that you want. So all this is essentially telling you is like, hey, looking at my different options that I have for my low intensity statins, this is when I'm using them, which we've like said a lot of times. And then looking at this is just helping decrease any type of risk, like the mortality benefit is starting to increase because we are decreasing the amount of LDL that person has floating around. And that is what our goal is for our patients. And then looking at over on this side, our triglyceride levels that are going to be very high, so those 500 or greater, that's when you see we start to add on our omegas and try to get them down even further because we have a better benefit in those patients as well, okay? So big thing is we start to stack, especially when we're looking at those triglyceride levels being that high, and then remembering when you're going to avoid using some of your medications because your triglyceride levels are already high, okay? So big thing that you're looking at for this lecture so far is that chart that we have and knowing when you're doing moderate versus when you're doing high and remembering the doses for your moderate, high, and low intensity. Remember I told you to remember the two ends and then everything else kind of falls in the middle. All right, check on learning. Which of the following medications is most likely to cause myopathy or rhabdo in a patient who's taking simvastatin? Right? If I added that on, I was more likely to see that occur. Not saying that you won't see it, but if you did see it, we're going to do more monitoring on that patient to make sure that they don't experience those myopathies. 77-year-old male with hypertension comes to your clinic for a cholesterol screen. He recovered from an MI 1 year ago. His LDL is high, his triglycerides are normal, his HDL is low. What is the most appropriate treatment for this patient at this time? What happened? So this one is put up here to trick you a little bit, right? So how old is this man? What are we doing once we hit over 75? We want to live our best life. We want to try to moderate, but we can potentially say, hey, I can have a conversation with you to put you on the high. So that's why our moderate was in green and then that high was in yellow. So if this is all that we have, yes, you can be like, okay, do I have patient conversation, right? So if I don't tell you about a patient conversation on your exam and you have somebody that's over the age of 75, what we have to do is the moderate, not the high, okay? So this was put up here to just be a mess on purpose so we can talk about it, okay? So if you had to pick one on here, right? I don't know what I would want to do with this. If I were talking to him, right, he's trying to take better care of himself. He already has a high risk, like he had an MI. I would put him on a high intensity statin because he already had an event, right? So this is that ACS event that person already had. But I would realistically like talk to him. But I would try to encourage him to be on high. So this was a conversation question, okay? Don't freak out question. This will not be a question that would be on your exam because you can't talk about it, okay? And just work through it. But this is like kind of what I want you to be thinking about, going through all of the different things that we can look at in our patient. Your big thing for this exam is going to be this. Wait, this slide, right? Your doses, and then looking at secondary and primary. Remember I told you, and I have to remember that when I go through and write the exam, that I'm making sure that I tell you if they had an event. And I will tell you what that ASCD event is, okay? I will tell you that it is an ASCD event. So, I don't know what I would try to push them for high, just because I like my numbers. But you could also look at C as one of your options. You could also look at C. Huh? We have a 5, but I wouldn't do that. I would try to get him on. Okay, what do we know? What are some side effects of your niacin? The big one that we talked about was what else? Okay. What are your high intensity statins that we have? We have 2 of them. A and R. Okay. So you're 20 to 40 and then you're 40 to 80. Remember, I will give you also the brand names in these as well. With our CK levels, with my statins, when am I checking it? The first time that I'm checking it is baseline. And then, or when I have any pain, I'm checking it. I don't have to say like, oh, I already checked you one time. I'm not worried about that at any point. And this is the other thing. Some patients can be on statins for years with no problem, and then all of a sudden they can start to develop myopathies. Okay? So you can always pull that CK if they come to you and they tell you that there's something wrong or they feel any type of muscle pain. I talked to one of my preceptors, and he said that he had a patient who was on one for years, and I was like, well, why would it all of a sudden start? I don't know. I was like, oh, okay. Because I was expecting to see that when you initially start something, not after you've been on something for years. Oh, there you go. Good job. Okay. Any other slides that are on there, those were just FYI slides that I pulled out of the lecture so that we didn't have to go over them. We will do 10 minutes now, and then we'll come back and we'll do pain series. So we're going to talk about pain. You're going to use these drugs a lot. I would have preferred that you could do this and prescribe me stuff now because we're old knees. But we're going to talk about pain. We're going to talk about topicals. I'm going to step out for a second because I have to go ask some questions. That y'all are probably going to be doing, so I need to make sure that we can see if we can wiggle some stuff. Dr. Shay Berg, works at BAMC. She is one of the preceptors that we have over there for like our pharmaceutical residency program. She does a lot of teaching, fellows, residents, pharmacists, what what PA old now? OTs. She teaches over there too. So we are now blessed to have her come over because I've been trying for a minute. I just always ask her last minute, and I caught her on time this time. So slides are going to look a lot better than what we're typically seeing. Okay, we are excited about that. And then I'll let you go ahead and take it away. So they're on the. Y'all have the slides. Everybody got them? In their PDF.
All right. So like was said, I am over at Vance. I've been there for about 5 years now. And my background is I actually did a residency in pain management and palliative care. So my background is in the mornings I work on inpatient palliative care. I support all of our folks who are transitioning to more of a comfort focus. There you go. Can you hear me? Yes, we can. All right. So mornings I'm in palliative care. I also see a lot of our palliative care outpatients, making sure that they're managed kind of in between appointments, seeing if we need to escalate to hospice, those types of things. So I work closely with our nurse practitioners and our physicians on that team. And then afternoons I'm with pain clinics. So we have PAs that are over there. I was grilling them this morning of, hey, what's going to be on your board? How do I need to ask this? How do I need to approach it? So hopefully I'm able to make sure that these things are catered to you guys and we focus on some of those highlights. One big thing that I was talking about when I was asked to do this lecture is I really want you guys to understand as we go through rather than memorize, okay? So we'll take it a little bit at a different pace is the hope, and my hope is that you guys do kind of understand what we're going through. So because I am a government employee, I have all the disclosures that I have nothing to disclose, and this is my information. There's going to be a handful of acronyms. I've tried my best to put the ones that we'll be using most often. They'll always be at the front or the top of the slide deck for each lecture series that we'll do. The objectives are just kind of piecemealed from the objectives that you have for all of the other sections. Again, today's point is just to do a generic overview of some of our pain concepts as it relates to pain. Alright, so we will talk about a little bit of background information, talk about what is pain, what's the pain pathway, what are some agents that we can consider, how do we pick those agents, and what's the good and bad about those different things, and we'll run through some cases. So first off, a couple volunteers. Why do we even care about pain management?
Pain sucks.
Pain sucks.
Going to be a lot of our appointments.
Yeah, majority of our appointments. Who thinks that they'll once they're PA, never going to see pain in their, no, couple laughs, right? So that is definitely one thing as to why I went into this specialty is, cardiac is fun, it's a cool system, but that doesn't impact everyone. Hem-onc is fun, but that doesn't impact everyone. So pain and palliative really is something that every single person at some point will go through and experience. So that very much was my passion as to why I went into this. All right, a couple questions. These will not be testable, I'll clarify. So what's the guess? What % of adults have moderate or severe chronic pain?
50.
Okay, we're all guessing these nice high numbers. So 25. Okay. Keywords here being moderate or severe. Okay, so what does that mean?
Survival.
Can you do daily activities?
Distracted. Okay, if someone, so I hear 6. So now we've talked about numbers. So moderate is going to start at what number? 4 and above. Okay, so mild is going to be your 1 to 3 range. Okay, severe is going to be your 7 to 10. And then chronic pain, what does that mean? Yeah, it's hanging around for a couple months. Okay, so putting all of those pieces together, 25 is still a large number of that population. Okay, what % of adults have disabling chronic pain that limits their ability to work and attend family activities? Okay, so we know it's lower. Good, good. Okay, so about 10%. So 1 in 10. All right, when you think about medications, what % of patients that received opioids for 3 months remained on opioids 4 years later? What number do we want this to be?
0.
0. Good. Over half. Okay? So this tells us that as we continue to prescribe, the longer we prescribe, the more likely it is that these patients are going to stay on this treatment long term. And
the typical duration for studies that are being done that are looking at pain medications?
A year?
Okay, during a year, right? We already talked about chronic pain, right? That's about a couple months, 6 weeks. Okay. So when we do these studies and they say, you know, this might be helpful, well, it was done for 6 weeks. This person's had pain for 10 years, 20 years, 30 years. And I'm going to trust data from 6 weeks. So a lot of the things that we'll talk about as well, we'll look at the studies, but we'll also tie in a lot of anecdotal experiences as well that has come forward and been published, but maybe not in a randomized controlled trial that we normally think of. Okay? So what is pain? Pain is an unpleasant sensory and emotional experience that's either associated with or resembles an association with tissue damage, whether that's actual or potential damage. There's 6 sub-criteria about the pain that we need to think about. So pain is always personal, okay? If someone comes into my clinic and they're just skipping along and they're like, my pain's a 10, that's their experience, okay? It's based on what has happened in their life and the different social factors that they've gone through. Pain and nociception are 2 different things. So pain isn't just because there was some injury that happened. Okay, nociception is that process of that pain going up to the brain, all those things from tissue damage. Throughout their lives, people learn what pain is. A person's report always has to be respected. So that person who comes in skipping and they say it's a 10, I can't just laugh it off. Right? I need to respect that that's what their experience is, and I need to respect that that's what their pain is. Typically, pain is going to be something that helps us, right? If I touch the stove, I hope that my body feels that so I can take my hand off the stove. Okay, but when we get into states that are more chronic, it can cause more adverse effects on function, social, and psychological well-being. When we talk to patients about pain, how we communicate is a really big thing, but know that there are a lot of different barriers. Okay, so if someone can't talk to us, that doesn't mean that they don't have pain or they can't express pain. So if someone had a stroke and they have trouble communicating that, if someone is blind and they can't look at the assessment that you're giving them, all of those different aspects are going to be things that we need to think about and make sure that we try to mitigate when we're talking to these folks. Remember that there are red flag symptoms when we're talking about pain, and these things may judge how we choose to treat these folks. So if someone has a fever, onset of acute pain or severe pain, the one that I want to point out here is going to be bone pain in a patient that has a history of malignancy or that awakens a patient from sleep. Okay? So that would be indicative of some sort of bone metastases. Right? These other ones somewhat make more sense, right? Pain following a fall or trauma, all those things. When we assess pain, we need to make sure that we're talking about what type of pain the patient has. Okay? There's different time aspects that we've already talked about, right? Acute, chronic, ongoing, all those things. And then we need to make sure that we're assessing not just what their pain is, but all the other aspects of their life that go into pain. If someone says, oh yes, I haven't been sleeping for the past week, right? Ignore it if it was your classmate saying that. Okay? Past week, they haven't been sleeping and their pain is a 10 out of 10. Okay, do you treat their pain or do you treat their sleep? Right? If someone's really, really sad because there's been, things that are going on, is it that, or is it their pain, or is it their sleep, or all of these other aspects that really play a role when we're trying to really assess what's going on? So looking into the generators, right? We have nociceptive, so this is the tissue damage that's going on. We have 2 subtypes, somatic and visceral. Somatic is going to be our stereotypical bones, muscles, joints, all those things. Visceral are going to be our organs, so it's going to be much more non-descriptive. Neuropathic is going to be some sort of lesion or disease of the nervous system. Things like neuropathy, phantom limb. These are going to be your burning, shooting, radiating, tingling type sensations. We also have psychogenic due to stressors, and then malignant, which would be cancer-related type pains. Durations have already been defined. So acute is going to be less than 4 weeks. Subacute is between that 1 to 3 months, and then chronic is over 3 months. And then our severity ranges are going to be 0, you have no pain. Right? So oftentimes folks will say, oh, their pain's zero, so that means it's mild. No, they have no pain. Mild 1 to 3, moderate 4 to 6, severe 7 and above. Alright. Questions thus far? Making sense? So excited. Oh my goodness. Love these lecture slides already. Alright, pain pathway. I'm going to skip this slide and go to the next one here. So this is the exact same thing, just with pictures instead of words, because I'm a visual learner. So the first step is we have some sort of injury that happens. That is called transduction, where we have an injury, and it's going to send it to our peripheral nerve fibers. Okay, where transduction is that step there. Then we need to get it up to the spinal cord. This is going to be our conduction. Okay? That's going to meet in the dorsal horn of our spinal cord there. The third step is we're going to get that transmission over via neurotransmission. That is going to go up to the brain. Your brain is going to perceive that sensation. Okay? And it's going to say, oh my goodness, yep, that's pain. Okay? Your body's going to try to fix it. So it's going to send a response. It's going to tell you to take your hand off the stove. But then it's also going to say, wow, now your hand is burning and that hurts, and it's still sending the signal up to me saying that you're in pain. I need to tell my body to suppress that feeling. So we have modulation, where we are going back down that spinal cord, going back to where that neurotransmission is happening and trying to inhibit that signal from going back up to the brain. Okay? So with this, can we assume where our medications work? Maybe. Right? So down that transduction, right, at the skin level, we're going to have things that are anti-inflammatories. If we don't have inflammation, we're not going to have that whole thing, that whole process go. Okay? Along that nerve conduction that's going all the way up, if we can use our anesthetics, okay, how are those going to work? Yeah, sodium. You guys already know all this. You're like, wow, this lecture series is going to be great. Okay? Sodium. We're just inhibiting that action potential. Right? That makes sense. If we just stop doing that, it can't keep going. All right? A lot of our agents are going to work at that neurotransmission area at the dorsal horn and the spinal cord. Okay? We're going to try to be suppressing and helping with that modulation pathway. Okay? So those agents are listed there. Again, the slide previously is just that same thing, but in words for you guys. Looking a little bit into each one of these steps, so with transduction, that first step. Here we see the tissue injury. We see all of these tiny little neurotransmitters and different things that are a part of inflammatory processes. Okay? So if you see agents that work on prostaglandins, this is where you see them. Okay? So again, we can put all of these drugs that we're going to learn about into this pain pathway to figure out where it is it's working, and we can help choose agents based on making sure that we have a different mechanism for a patient if one thing's not working. Okay? We're adding to it. When we look at transmission and modulation in that spinal cord, right, we're going to look at our inhibitory neurotransmitters, and we want to enhance those. We want more inhibition. So we want to increase GABA and we want to increase glycine. We also want to suppress our excitatory neurotransmitters. We don't want that signal going. Right? So glutamate is going to be a really common one that we see among our pain meds. And then as you guys already mentioned, right, all this sodium, chlorine, potassium stuff is going to be in that action potential. So we see a lot of our agents are going to help mess with that signal. Okay. So looking at suppressing excitatory neurotransmitters, this next slide is going to be an example. Okay, your slides that were downloaded do not look as pretty because it's the end of the cycle. So previously we have our presynaptic neuron, our postsynaptic neuron, and we have NMDA receptors that are on our postsynaptic neuron. Glutamate is in that N terminal. Okay, get ready, get ready. We're going to bind, that acts as a key to have calcium influx into the cell or into the neuron, and that's going to cause that action potential. Make sense? Awesome. Okay. One fun thing about NMDA receptors is that they have magnesium plugs. Okay, so we can have magnesium that goes onto those, acts as a plug naturally. Glutamate tries to bind, magnesium says not here. Nope. So guess what we can use as an OTC option for our patients with pain? Magnesium. Okay, so if someone has low magnesium in their body, they probably have more pain. Okay? We also have drugs that act as an MDA receptor antagonist. So they go in, they bind onto those receptors, glutamate tries to bind, and it says not here. Okay, so we're suppressing that action potential down the way. Okay, makes sense. Perfect. All right, here's another picture that looks at this pathway, just in a different subset. And then we see the modulation kind of at the bottom where we have different neurotransmitters down there. So we'll talk about agents that have serotonin. There's lots of serotonin in the body. Some are inhibitory, some are excitatory. In this process, it's inhibitory. So it'll depend on different agents. So know that it's not completely across the way that some things are going to do an inhibitory action every single time. Okay, so just be mindful of that. All right. What do we look for in a drug? So, oh, please. I'm asking rhetorical questions, and you guys are taking it serious. I love it. All right. So, drug-related variables and patient-related variables. Okay, so when we look at drugs, things that we want to talk about, which we already have, right? Mechanism and the site that it's working at. Those things are important. What are the side effects, the precautions, the contraindications? How does it work in the body? How does the body work on the drug? What are the drug interactions? Drug disease interactions. So if someone has heart failure, okay, and we give them a medication that causes increased fluid or edema, that's not going to be a good thing, right? So that's a drug disease issue. Available dosage forms. If someone's having trouble swallowing, if they don't want to take something 7 times a day, does it have a patch? Okay? Does it, if we can't get IV access because they're dehydrated, can we give it IM? Okay? And then certainly the cost. Patient-related variables are going to be dependent on what type of pain they have, what comorbidities they have. So do they have cardiovascular, renal, hepatic, adherence concerns. So this would be someone who forgets to take their medications. I'll be biased and say our teenagers. Okay? Sometimes they're maybe not the best at remembering to take things. So picking something that has a long half-life will be helpful as well when we think about drug-related variables. Aberrant concerns. This would be someone who potentially you're worried about is misusing, is selling, is giving it to their dog, is taking their dog's meds. I had a patient last month admit to that, and we had to have a little conversation about that. Okay. What is their age and size? So this is going to be helpful when we're thinking about if a drug works in the fatty tissue, if it gets stored in the fatty tissue. Okay, if someone has more fat on them or not. What support system do they have? Do they have the dexterity to open a pill bottle, to push a pill, to peel off the back of a patch and put on? All of those things will be helpful to know. And then their general understanding and financial status. All right. Controlled substances. Medicinal use. Which ones can we use? Which ones can't we use?
1 through 4.
We can't use
5.
1.
Oh,
Okay. This is why we ask. Okay, we can't use 1. We can use 2 through 5. C5s, I put in quotations of OTC status because there are some states that allow some C5s to be like ledgered, if you will, that the pharmacist can give them. Not many. Okay. Psychological and physical dependence. Extremely high. Down to less and less and less and less and less. Okay? What are some examples of C1? Cannabis, LSD, marijuana, okay. Besides feeling a little quiet.
Big meths on
What was it?
there. Like methamphetamine.
Okay. Yeah, meth.
2.
What about an opioid? The whole opioid epidemic.
C2, for 3.
Think about which one is a C1. Heroin. Okay. Yeah, that one. You got it. Okay. C2s. What are some examples of C2s? Cocaine, we know that one. Good. You guys already hit one up on my fellow. Every single time. I'm Jeopardy, I feel it. What else? Okay. So some of our amphetamines, okay, our Adderall type things. Okay. The majority of our opioids are also C2s. Okay, so the majority of the ones that we'll talk about will be C2s. Our benzos are going to be a 4. Tramadol is a C4. And then C5s we think about is Lyrica or pregabalin. What do these things mean other than what's up here? How does it impact you in your prescribing and your patients and all that stuff? Yeah. Yeah. It impacts the refills and all of that fun stuff. All of that. Okay? Some sites may require you to visit with a patient depending on what the controlled substance status is. All right. Other agent considerations. So we need to think about how our body works on the drugs. So how our body is metabolizing these agents and breaking them down. So the most common one is 3A4. Beautiful. Our second most common one is 2D6. We can read the graph. I love it. We're doing great today. What exam, right? Okay. So 2D6 is an interesting one that comes up in pain as well. 2D6 can have a lot of substrates. So we have 2 that are prodrugs. What is a prodrug mean? Yeah. You guys know? I'm just standing here asking questions. This is great. Okay. So it needs to be metabolized to something to make it more active. Okay. And so codeine and tramadol are 2 that go through that 2D6 pathway that then get to become way more active. So tramadol, when it's metabolized by 2D6, its metabolite, M1, is 300 times more potent. Okay? It's working. Okay, tramadol not working. Okay? We also have inhibitors. So example of inhibitors that we'll talk about, many of our antidepressants inhibit that metabolism pathway. So what does that mean if someone's taking tramadol? So it will be metabolized, it won't be metabolized? It won't be. So is their pain going to be controlled? No. So how often do I get patients that come into clinic and I'm like, oh, my doctor's put me on tramadol, and then they just added duloxetine to help with my pain. And I'm like, oh, how is your pain? And they're like, it's worse. I was like, I bet it is. Let's talk about it, right? Typically we're able to work through it. Okay, other fun things that we think about are our 3A4 inhibitors and inducers. Okay, so this is my favorite mnemonic that I've created. If you guys have better ones or better letters, if other instructors have told you other things, please do. So our 3A4 inhibitors are G-Pac-Man. So when a ghost, your G, hits Pac-Man, what happens to Pac-Man? But first it freezes. Okay? So Pac-Man's eating, and then all of a sudden it stops eating. Okay? So that's how we can remember our G-Pac-Man. These are inhibiting that metabolism. Nothing more is getting eaten. Right? So we have our agents there. Our inducers. Pop rocks. Remember that candy? Put it in your mouth. Fireworks, everything. It's on fire, and then it's gone a second later. Just like Pop Rocks, right? You're going through everything, you're metabolizing everything, and then it's gone. How I always try to remember which drugs are in which class is many of our seizure medications, the ones where you're shaking and moving, are going to be on our Pop Rocks. Okay? Helpful mnemonic? Gonna have like tears of happiness pretty soon. Like, oh my god. First 20 minutes and here we are. Okay. Some terms to think about. So what does placebo mean?
Fake drug.
Fake drug, but it works. Right? What does this mean? That's exactly what placebo is, right? It's the fake drug that works.
Power of positive thought.
Yeah, kind of positive thought stuff going on. Okay? What if I tell you this is a sugar pill? Does it still work? It does. It does. Even folks that know that they're getting placebo, they still have positive outcomes. Okay? What is in a typical drug trial, again, not on the exam, but just fun knowledge, typical drug trial, if you give somebody a placebo pill, what's the expected efficacy that they earn from the drug, percentage-wise, or from the placebo?
20%.
20%. 20%. Okay? So in order for us to find something significant, in pain we look for a 30% benefit. That is from placebo. Meaning our patients typically need to show a 50% benefit in order to be positive. Okay? In a lot of the trials. So when we're talking to patients about their pain, and we're trying to figure out what agents are helpful, or we're trying to figure out is this agent helpful enough, we're pretty much looking to get at least 30 to 50% benefit in their pain reduction. Okay, someone comes in at a 10, we need them to get to a 7. Okay, 7 to 5. Rarely does that 5 happen. Okay, so placebo is going to be a positive effect from an intervention, even though there's no underlying efficacy, technically given to it. Okay, what about nocebo? Okay, opposite. What if I say, here's this drug, it's going to make you profusely vomit, it's going to make you never sleep again, it's going to do all these things, but it works really well, but all of these horrible things. You're going to lose all your hair, you're going to shrink. So it's a way of having a negative outcome to a drug. Okay? So a negative effect from an intervention, and again, not necessarily related to the exact tolerability concern. So this is common in some of our folks who may come in and be like, oh, I read the package insert and I had all of those side effects. Okay, you'll hear that. Typically it's going to be a nocebo thing that they're going through. And so try to meet them where they're at, talk to them a little bit. All right, number needed to treat, number needed to harm. We talked a little bit about that, right? So number needed to treat, we're looking for that 30% reduction in order to get that number. Have you guys talked about these numbers for other drugs anywhere else? No. Do we know what number needed to treat is? Maybe. Okay, I'm seeing no's. Seeing no's. So number needed to treat is going to be how many people you need to treat, whether it's for pain, for statin, for whatever. How many people you need to treat to have one person have the positive outcome that you're looking for. Okay? So ideally, your number needed to treat would be 1. You treat one person, they have the positive outcome. Okay? In many of our secondary prevention for cardiovascular things, I'm glad Mark's not in here, it's over 100. Okay? Some of our statin therapies, upwards of 300 is the number needed to treat. Okay? It depends on the situation, but from a palliative standpoint, that's the number that I look really closely at. Is what is the true number needed to treat, and do I think my patient is that golden patient that's getting this benefit? Okay? Number needed to harm, opposite. How many patients does it take to treat for one person to have a side effect? Or that harmful effect that they're looking for? Okay, what do we want this number to be?
Really high.
Really high. Really high. We want it to be infinity. Okay? So in pain, typically our number needed to treat for most of our drugs are going to be somewhere between 3 to 8. Okay? Meaning that we'll have to try a couple different things. Number needed to harms are going to be anywhere from 10 to 30-ish. Okay? Again, it depends on the patient. But that does tell us that our agents are hopefully more effective than they do have tolerability concerns. Okay. All right, how about these 3 words? Dependence, tolerance, and addiction.
Very complicated.
Let's say you drink coffee, energy drinks, whatever it is, okay? If you are dependent on that, that means that if I take it away, how are you going to feel? Not great, okay? So it means that if you were to remove something, you would be irritable, you would go through a withdrawal, okay? I already know I'm dependent on chocolate. You take it away, not happy. Sugar, besties. Okay? I'm dependent on it. Okay, what's tolerance? Tolerance is this whole year, you guys have been drinking 3 cups of coffee a day. Okay, hopefully you laugh because, I drink so much less than that. Okay. So maybe, right, last year, maybe you started at 1 cup a day. What happened after a month or 2?
Didn't feel effective.
You needed to go a little bit more. Went up to 2 cups a day. Okay, another semester happened. Now what? 3. Okay, so in order to get the same effect, you have to increase your dose. Okay, so that's tolerance. You need to increase your dose to get that same effect that you once did. And then addiction. You drink coffee. There's nothing wrong with that, but at what point do you become addicted?
More extreme withdrawal.
Okay. So addiction doesn't have to deal with the dependence or tolerance, so the efficacy nor the tolerability of it. Okay, but it's using it despite known harms. Using it and avoiding work or family situations. Okay, you're at your kid's birthday and you're like, you know what, I gotta go do this. Drink my coffee in my car. I don't care if it's warm, I'll do anything for it. So you get those cravings. Okay? You're missing family functions. A great deal of time is spent about how to acquire it. Okay, so it's not related to the dose, it's not related to how helpful it is or how harmful it is. It's related to that drive and how much time that's taking for you. Okay? There was a reading that should have been uploaded as well called Fennerup is the primary author. It is there for your assistance. If anything, there's a really wonderful picture, I believe on page 2 or 3, that has all of the pain pathway and all of the drugs and where they work in that pain pathway. Okay, so if you don't read it, it's fine, but if you want to take a look at that picture, I think it will be helpful for you guys. All right, and then when we think about our agents, so this is commonly how I work with my fellows when they come to me saying, you know, Sherry, how do I treat this patient? I go through, okay, are there any herbals or supplements that you would give them? No. They're already on 50 million drugs. I'd never do that. Okay. Are there any topicals that you would give them? Oh, I don't think they're motivated. They're not going to do that. Okay. How about Tylenol or NSAIDs? Okay, Tylenol being acetaminophen. Either of those. Oh, well, they have this or that issue, and that's why we can't give them that. Okay? And so this is just one way to kind of work through this. It isn't always going to be this linear, but I think as you guys are studying, if you're just trying to, you know, go back to the basics of, okay, what drugs are in this class, what drugs are in this class, how do these ones work, this might be a very, very simple way to look at it. But what drug do you pick? Okay, it's not a 1-hour lecture, unfortunately, for all of pain, so we'll be talking about that for the next couple days. But the CDC recommends that people that have pain need to receive appropriate pain treatment with careful considerations of the benefits and risks of all treatments in the context of that patient. Right? Clinicians should collaborate with the patient when they make treatment decisions and design a treatment plan, including when they initiate or change medications. Factoring the opioid epidemic was a full-blown opioid epidemic, which was what years? Any idea? 2000-ish, okay? 2005, 2012-ish, I would say is kind of when the bulk of it was. The WHO analgesic ladder was something that was published, and we'll talk about many of the limitations that are tied to it. But the WHO ladder specifically talks about how do you treat patients that have cancer-related pain. Okay? So if I have cancer, okay, and I trip and fall and twist my ankle, can I use this treatment approach to treat my twisted ankle? No. Why?
Not cancer related.
Yeah, it's not pain related to my cancer. Okay, so it's only the pain that's related to the cancer. So if the cancer has gone into the bones and you have bone pain because of that, sure. If it has gone to your brain, to your lungs, wherever, sure. But if something else happened, you would not use the WHO ladder to treat them. So how the WHO ladder goes is based on the severity of their pain, and that's it. Do they have mild pain? Use a non-opioid. Do they have moderate pain? Use a weak opioid. And we'll talk about weak opioids. Typically the ones that we think about are going to be codeine, tramadol, or hydrocodone with Tylenol, or oxycodone with Tylenol. And we'll get into that when we talk about opioids. Okay, but moderate pain, weak opioid, and non-opioids. Severe pain, strong opioids, right? Or non-opioids. If they still have pain, despite starting them at those steps, you can then do other interventions. The big limitation is that it questions the appropriate in non-cancer related pain. Okay, so what happens when they do roll their ankle and they are at a 10 out of 10, they broke their arm, they touched the stove, all those things, do you just throw them on strong opioids? Really depends, right? However, that is a widely used practice. There is limitations in individualization. So is this person at risk of falling? Or do they live by themselves? All these things, and now you're just going to start them on a strong opioid, so it doesn't individualize it to them or the type of pain that's going on. And then it is outdated. However, as I was updating the slide, I was happy to see that it's supposed to be updated sometime this year. So hopefully not in the next week, but sometime this year. All right, 2012, so a year after the WHO had updated the most recent version of their ladder, there was a platform that was published. And so the platform takes it from just nothing to mild, to moderate, to severe, to keep doing things. They added this kind of bench saying, sure, you can do this, but try all of these other things too. Okay, and they're all equally on that line. Okay. Some example guidelines, again, not testing on this, but I think it may help as you guys go through this to really understand where these guys fit. So when we're looking at just chronic pain or acute musculoskeletal injuries, this is what the guidelines say. And these are both within the last 5 years. So in chronic pain, pretty much just antidepressants. Okay? And again, our serotonin is going to work in that modulation area. So we're just telling that brain to stop getting that signal going up there. Okay? When we're looking at our acute musculoskeletal pains, so you broke something, you tweaked something, you strained, you sprayed anything, typically we're going to look at our topicals, and then our Tylenol or our acetaminophen Tylenol, or our NSAIDs. Okay? Both of them don't recommend reaching for the opioid first. Okay? Low back pain by far will probably be the most common thing that you guys experience and look at. So these are the first two columns are the most recent guidelines for acute low back pain. The next two are chronic low back pain. The next one is sciatica, and the last one is just low back pain in general. However, that one is fairly outdated, about 10 years old now. But we can see that, again, it kind of just hovers in this NSAIDs and antidepressants maybe across the board. Okay? So very, very interesting approaches that we don't completely follow that ladder for our non-cancer pains. Okay? All right, so how do we do it? We need to make sure that we're determining which agent is appropriate, depending on the different assessments and presence of these different red flags, the pain generator. We need to encourage patients to keep a pain diary. Okay? I always say that I'm the worst example of a patient. I have a headache, I take some Tylenol, and 2 hours later I'm like, oh, my headache went away. It definitely wasn't the Tylenol, right? When it probably was the Tylenol. Reassess for the efficacy, so how helpful is it versus the tolerability? How many side effects are you getting from it? And then making sure that we either discontinue, we rotate to something else, or we modify what dosing we're using for them based on those outcomes. All right, we're going to go through a couple patients. We're going to be thinking about what red flag symptoms do they have, what type of pain do they have, what is the duration and severity of their pain, we're going to try to classify it, and then what approach might we use for them. Okay, so we have Alex. He's a 43-year-old male. He presents to the emergency department in severe diffuse abdominal pain and back pain that has been awakening him from sleep. Imaging is significant for widespread osteolytic and osteoblastic lesions and asymmetric colon wall thickening. So take a second, think about, does he have any red flag signs? What is this pointing to? What type of pain is this? What is the generator of it? And then what would be your treatment approach based on this? Just share with the partner that you're sitting near. What type of pain, what red flags?
That's crazy. Orthopedic class, we said it keeps you awake.
Alright, so what are we seeing? Red flags.
Losing sleep.
Awakening from sleep. Okay, what do we think is going on with them? Potentially, yeah, big C, right? Potentially cancer. Where do we think it's coming from?
Colon.
Colon, okay? What other things are happening from that? Is it just in the colon? No, bone mass, okay? He comes to the ER, it's a severe pain. How are we going to treat him? Strong opioids, why? Severe pain and cancer related. Okay, makes sense. All right. 22-year-old female, mild pain, has a sport-related injury that occurred last night because she was doing intramural soccer. Her imaging is unremarkable and she's diagnosed with an ankle strain and is advised to rest, elevate the ankle, and apply local cool compression. Okay, what type of pain? Are there red flags? How would you treat it? Alright, what are we thinking?
Look her up with
No
the
red flags.
inside and get out.
Acute chronic musculoskeletal, okay? So somatic type pain, no susceptions going on. We can treat it at the site of injury. NSAIDs, you guys already know it. Okay, 48-year-old male, 5 out of 10 pain, moderate. Is chronic axial low back pain. He has imaging that was remarkable for age-appropriate degenerative changes. What does that mean? We get this every single hour. There's a patient that comes in with this. What does it mean? It means that they're a human, and as you age, your body breaks down. So it's age-appropriate degeneration of what's going on, right? He finds it difficult to stay motivated to complete his home exercise program, which is also known as PT. Okay, so who doesn't want to do their home PT? And has historically not been interested in meds because he would rather tough it out. What might we consider in him?
Why are you using
Are we going to give him opioids?
No.
Fentanyl all the way? See a couple say yes, right? That's going to be a negative. Okay, so no opioids. Is moderate pain though? Can we do a weak opioid? No, because it's chronic. Is it cancer related? No. So we really want to focus on all of those other options first. Okay? So we'll talk in the next couple days, right, what other options might be better for our patient Scott here. But it's not going to be opioids, and we know why. Okay, last we have little Milo. He's going to go an extensive dental procedure, and the pain from the procedure is expected to be severe and persist for a few days following the procedure. He's going to do some non-Pharm interventions of cool compression and rest. What might we do for him?
Tylenol, NSAID.
So I'm hearing some Tylenol NSAID. I'm hearing some other things that are picking up. So I think you guys have maybe heard about all these other things in the past. I heard someone say some comments about a 12-year-old. Do you know something about 12-year-olds? And if not, then it's fine. We can talk about it later. So in PIM, we may consider what? We may consider an opioid. Why?
It's gonna be a lot of things.
It's acute and it's short-lived. Okay, so for a few days, right? Where Scott, our last patient, who's crying. Our gal before that, it was strictly musculoskeletal. Okay, this is a procedure, and so sometimes in procedures we can consider doing an opioid as long as it's for that acute phase. In our kiddos, we do need to be careful about which opioid we choose, and so that we will get in as well. Okay? To wrap it up, pain is subjective. It's a personal experience. It should be respected. It influences our function, social, and psychological well-being. It should be assessed through a variety of age-appropriate measures. Also making sure that we're asking other folks kind of what they're seeing and noticing as well. The pain pathway involves transduction, conduction, neurotransmission, perception, response, and modulation. And then our therapies work along that pathway, and making sure that we're making it patient-specific. So some additional resources, again, none of these you have to look at, but if you want something for a reading, or at least for that picture, I would recommend looking at that article, getting that page 2 or 3, whatever that is, that has the picture on it of that pain pathway with all the drugs. And then there's probably a 2-paragraph thing on each drug class, so if you wanted to review anything, that would be potentially helpful for you. There's some different training modules that are available on train.org. It's a part of the CDC and the VA chronic pain training modules that you guys are welcome to look at. UC Davis also has a variety of pain lectures if this is something that interests you guys.